Hi, my name is Kelsey Chapman, and today I'll be doing a snippet for bronchodilator, specifically for asthma. Asthma is a chronic condition found in both children and adults, and it is an inflammation of the lungs and makes it difficult to breathe. Certain markers and receptors within the lungs are affected by allergens and different inflammatory markers, causing episodes of wheezing, coughing, and chest tightness. This may be familial and it may be confirmed with the lung function testing, which results with the test being less than 80%. When a beta-2 agonist is given and these numbers improve with the testing, then it is said the patient has asthma. It's important to note the beta-2 agonist improves the function of the testing because we'll get to that later on with the bronchodilators. Symptoms may be daily or intermittent. The smooth muscles in the lungs have an inflammatory response or become constricted when the beta-2 adrenergic receptors are inflamed or are unable to provide the relaxation needed. The mode of action. For the albuterol, the mode of action is that it provides bronchodilation and relaxation of the smooth muscle in the bronchi. The smooth muscles in the bronchi contain large amounts of beta-2 adrenergic receptors, and these receptors are activated when the albuterol is inhaled to allow for further relaxation of the smooth muscle. It is used to provide relief in bronchoconstriction, provides a rapid response within 5 minutes. It can be given in puffs as an inhaler, or it can be given as a nebulized concentration for more severe asthma or for rescue breathing, where the patient needs to use a rescue inhaler. There are drug interactions with using albuterol. Typically, it is very safe to use in combination with other respiratory drugs to control asthma. However, beta blockers, diuretics, digoxin, and epi are contraindicated specifically with the use of albuterol because of the mechanisms of action on the body with these drugs as well. It does not provide any anti-inflammatory effects, and it is not recommended for single therapy dosing for asthma. However, if the patient has very mild asthma, not needing to use a rescue inhaler, but just maybe once a month, it is okay to prescribe without any kind of control or med. This is just important to know about the short-acting beta agonist. It's very effective if taken correctly by way of inhalation through an inhaler device or nebulizer. This medication is safe. It does have adverse reactions that should be noted. Tachycardia is the number one symptom. Jitters, tremors, hypokalemia is one that patients may not be aware of, but this is something that is caused from albuterol. So if your patient has a history of low potassium, it would be advised to maybe try them with something else, or just to remind them about this adverse effect of the albuterol. Albuterol is very inexpensive and can be used pretty easily because it's able to be given from a pharmacy. Insurances do cover this medication, and so it can be cheap, about $15 to $25 with most insurances. There are generic forms available as well. The expected outcome for the use of albuterol is that it relieves bronchoconstriction with dosing of 2 puffs every 4 to 6 hours as needed, and to use as a rescue inhaler. Salmeterol provides a long duration of action over 12 hours. This is the long-acting aspect of this bronchodilator. Salmeterol has a lipophilic chain that binds to the beta-2 receptors on the smooth muscle wall, which allows it to kind of stay put there on that smooth muscle wall and keep acting on it, making it last longer for the full 12 hours. It is metabolized in the liver and has a half-life of 5 hours. There are some drug interactions that are similar to the long-acting as the short-acting bronchodilator, so stimulants and beta blockers are still going to be contraindicated. They should not be used together. It should be noted that with a controller medication that the salmeterol is appropriate to use. And it should not be used alone. It's definitely needed to be with a inhaled corticosteroid or packaged together as a dose, or it can be given separately, but it definitely needs to have a controller medication available with it. So the long-acting beta agonist cannot be given just alone to control asthma by itself. So patients that have a cardiac history, diabetes, hypokalemia, hepatic disorders should be monitored very closely, as this can also cause some low potassium levels in the blood. It should not be used alone. That's the number one key point of the long-acting, is that it has to have a controller medication with it. This is actually a U.S. box warning, as using the long-acting alone can increase asthma-related death. The cost, it's very expensive to get the long-acting only. It can be about $200, but it is recommended and highly, highly recommended that if combined with the inhaled corticosteroid, then the price can be cheaper, about $50, and insurances may cover any kind of generic version as well. The expected outcome for the long-acting is that it has a longer term of 12 hours to provide against bronchoconstriction. And the onset time is typically within about an hour, 30 minutes to an hour, so it is not to be used as a rescue inhaler. In summary, both bronchodilators are prescribed based on the patient's severity of asthma. The short-acting should be given to all patients regardless of severity of asthma, mild to severe, just so they can use that rescue inhaler and get that immediately bronchodilating aspects from it. And then the long-acting should be given to patients with more severe asthma that need a little extra help with the bronchoconstrictions that they're having, maybe to have so it can be the full 12 hours. But once again, that medication, the long-acting, must be given in prescription with inhaled corticosteroid control or medication. It cannot be given alone. So thank you for listening. I hope you've learned a little something about bronchodilators. Thank you.